Hello, everyone, and welcome to today's Provider Education Network webinar. I'm Deontay Bayham, the Provider Engagement Specialist at Wellhead, Louisiana, and thank you so much for joining us today. Today's webinar is DSMES via Telehealth, How RHCs and FQHCs Can Get Connected, presented by Danae Aber, Healthcare Innovation Supervisor with the Wellhead, Louisiana Division of Rural Health Advancement. I will now hand it over to our speaker, Danae.
Sorry, I was muted. Thank you, Deontay. Good afternoon, everyone, and thanks for joining us today. Today I'm going to talk about DSMES via telehealth. And just to note that the information in this presentation will be relatively high level, but if you need more information, anything presented here, we have a lot of resources on our website at walpen.org, or you can even send us an email, lahead@la.gov, and the question will be directed to the appropriate person. So again, this presentation will provide a high-level overview of what DSMES is, the structure and the requirements and the benefits to make sure that everyone has at least a basic idea of what DSMES is. And this presentation is targeted specifically for rural health clinics and federally qualified health centers. So I'll focus on the requirements and reimbursements and the limitations for those providers. And then we'll move into telehealth information, first with how RHCs and FQHCs can get their patients access to DSMES via telehealth, considering the limitations with both the DSMES program and the telehealth regulations. And then I'll talk a little bit about the different considerations that have to be made for a telehealth program versus an in-person program. And then the billing requirements for DSMES via telehealth. And then finally wrap up by providing some information about the DSMES via telehealth project that we at Wellhead are working on and how you can get involved in that project if you're interested. And then of course, I'll be happy to answer any questions that you might have at the end of the presentation. So with that, I'll jump into the overview of DSMES. So DSMES stands for Diabetes Self-Management, Education, and Support. And it's the ongoing process of facilitating the knowledge, skills, and ability for diabetes self-care. So generally through DSMES, providers and educators are trying to help patients with diabetes be able to better manage their health and their care related to diabetes. And the programs are typically delivered in small in-person groups or in a classroom setting. Some programs, especially recently, are being delivered via telehealth. So in order to be considered a formal and reimbursable DSMES program, the program must be recognized by the American Diabetes Association, ADA, or accredited by the Association of Diabetes Care and Education Specialists, ADCEs. So in order to be recognized or accredited, a DSMES program must meet these 10 standards listed here, and we will go through each one of these quickly. And the standards are also linked here on this slide, how to access them when the slides are available after this presentation. So the first standard structure. So the providers of DSMES services have to define and document the mission statement and goals of the program, and then the services be incorporated into the organization, and that there has to be documentation of where it fits in the overall organization structure and the overall mission and goals of the organization as a whole. Standard 2 is stakeholder input. So the provider has to seek ongoing input from stakeholders and experts to promote the quality and enhance the participant utilization. So ADA requires a formal advisory board. CES does not require a formal board, but the stakeholders in either case should be representing the community where the services are provided. Standard 3 is evaluation of the population served. So the DSMES provider needs to evaluate the communities that they serve and the resources, the design and the delivery methods that align with the needs of that population. So data, assess the barriers and the factors that may prevent the population from accessing services, and then have plans and actions in place to overcome and address these barriers and the gaps in service. They also have to have a quality coordinator overseeing the services. So they are designated to ensure the implementation of the standards and oversee the services as a whole. They are responsible for all the components of DSMES, including evidence-based practice, service design, evaluation, and continuous quality improvement. And this person should have a diabetes related background, and they are required to accrue 15 hours of diabetes related continuing education every year. Standard 5 is the DSMES team. So at least one of the team members responsible for facilitating the education must be a registered nurse, a registered dietitian, nutritionist, or a pharmacist with training pertinent to DSMES, or another healthcare professional who holds a certification as a diabetes educator or a certification in advanced diabetes management. Other healthcare workers or diabetes paraprofessionals can contribute to the services with the appropriate training, but they must be supervised and supported by at least one of those listed team members above. There must be a curriculum in place reflecting current evidence and practice guidelines with criteria for evaluating outcomes to serve as the framework of the program. The needs of the individual participant will determine which elements of the curriculum are required for that particular participant. The essential elements and content areas that need to be included are listed here. And they include treatment options, healthy eating, physical activity, medication, monitoring, preventing complications, healthy coping, and problem solving. And then the program needs to be individualized for the participants. So the needs will be identified and led by the participant with assessment and support from the team members. So the participant and the team members work together to develop an individualized plan for each participant. The assessment requirements are a little bit different for the ADA and the ADCES accreditation, but both include elements related to medical diabetes history, diabetes knowledge and health literacy, emotional response to diabetes, support systems, diabetes management skills, and lifestyle practices. The participant also needs to be made aware of options and resources available for ongoing support of their education and help them select the option that's best to help them self-manage their needs going forward. So this can include support groups, community organizations, physical activity programs, things like that. The DSMES provider has to monitor and communicate whether participants are achieving their personal diabetes management goals and other outcomes to evaluate the effectiveness of the interventions, of course, using the appropriate measurement techniques. So ADCES requires evaluation of a behavioral and a clinical outcome, and then ADA recognition requires evaluation of at least one behavioral goal and another outcome, which can be clinical, it could be quality of life, satisfaction, etc. And then the final standard is quality improvement. So the quality coordinator has to measure the impact and effectiveness of the services and identify areas for improvement by conducting a systematic evaluation of process and outcome data. So ADCES accreditation requires assessment of clinical outcomes, process outcomes, and behavioral outcomes. ADA recognition requires evaluation of at least one participant behavior outcome and one other participant outcome. Both do require documentation of continuous quality improvement. So As you can see, the DSMES program is pretty involved and has some pretty specific requirements, but what are the benefits? So why would a provider want to establish a DSMES program? There are several benefits at a high level for both the provider and the healthcare system as a whole. So first, it helps to support all the stakeholders, the providers, people with diabetes, and the community in addressing diabetes-related needs. It increases the quality of care and reduces costs by helping to mitigate some of the more devastating and costly complications that can result from diabetes. And although the program itself doesn't necessarily generate a lot of revenue, there is often an increase in indirect revenue from things such as lab testing. And DSMES can also help providers to adhere to the standards and goals for healthcare reform and to meet those quality assurance standards for patients in our medical home and for accountable care organizations. The real benefit, though, is for the patients. Studies have shown that patients with type 2 diabetes who participate in DSMES show an average decrease in their hemoglobin A1C of anywhere between 0.57% and 1%. Participants show improved lipid profiles, decreases in weight and blood pressure, and reduced onset or progression of diabetes complications. Participants often have a better quality of life as the program helps them to implement long-term lifestyle changes and enhances their self-efficacy and empowerment over their health. And participants also learn healthy coping, and so they have less diabetes-related depression. And so this program can make a real difference in patients' lives. And we've heard stories personally from patients who've had diabetes for many years and never received education. And once they received education, even just taking one class, they learned basic skills that they could quickly and easily implement into their lives and helps them better manage their diabetes. So we know the program's beneficial, but what does the coverage look like? So first, I do want to clarify, Medicare and Medicaid documentation uses the terminology diabetes self-management training, or DSMT, rather than DSMES. But it is referring to the same service, so the terminology is just a little different. These services are only covered by Medicare if the provider certifies that the services are necessary, which means an order is required. So a patient can't self-refer, there has to be a physician referral. Part B covers 10 hours of initial training and 2 hours annually of follow-up training. And only accredited or recognized programs can be reimbursed. And of course, the provider has to be enrolled in Medicare in order to receive Medicare reimbursement. There are some specific requirements for the initial training and the follow-up training. The initial training is only available to patients who have never had DSMES training before, and the training must be furnished over no more than 10 hours within a 12-month continuing period. The training is usually furnished in a group setting with the exception of 1 hour of individual training, which is usually insulin training. For the follow-up training, no more than 2 hours per year is covered. It's delivered in a group setting, but not all the individuals in the group have to be Medicare beneficiaries. The training has to be delivered in increments of at least 30 minutes, and the patient has to be documented as having diabetes by their treating provider. Unfortunately, Medicare does not reimburse RHCs separately for DSMES services. It's considered included in that all-inclusive rate that RHCs get for medical visits. So there isn't a separate a reimbursement for DSMT services. FQHCs can receive separate payment for these services from Medicare. The billing rules vary a little bit between the all-inclusive rate model and the prospective payment system models. So we'll look at those, the differences between those. FQHCs under the all-inclusive AIR model, the payment is made at the AIR rate, and can be made in addition to another qualifying visit on the same day. So if you have a medical visit and a DSMT visit, you can bill those on the same day and get paid for both of those under the AIR model. They only reimburse one-on-one face-to-face encounters, no group visits. And you would bill the G0108 code, which is the DSMES specific code. If you are an FQHC under the PPS model, the payment is made at the PPS rate, but there is no separate payment. If there's another qualifying visit on that day, you would just get paid for that qualifying visit. And again, it must be medically necessary and one-on-one face-to-face, and it's billed with those G0466 or G0467 encounter codes. So Louisiana Medicaid coverage, they also require an order from a primary care provider and has pretty much the same initial training and follow-up training hour limitations as Medicare. The requirements are very similar. You'll see that they do specify in the initial training that the sessions have to be at least 30 minutes. Otherwise, the requirements for Medicare and Medicaid hours and training look pretty much the same. The big difference is that Medicaid does not reimburse RHCs or FQHCs separately for DSMES encounters. They are considered part of the encounter rate. However, they do specify that a DSMES only encounter does not constitute a visit. So you can't bring a patient in and have just the DSMT, DSMES encounter and bill for an RHC or an FQHC visit. It's not considered a visit on its own, and it's not separately payable under Medicaid. So those are the reimbursement rules. And because, as we've seen, it's very limited and really non-existent for RHCs, most RHCs and FQHCs don't have a DSMES program, and instead they refer their patients out to another DSMES provider. But as I'm sure we all know, many times, especially in rural areas, it's really difficult for patients to get to these DSMES providers, but we still want the patients to have access to these services. So let's talk about providing access via telehealth. First, I want to make sure everyone is on the same page about terminology. The distance site is the provider site. So in this case with DSMES, this would be the DSMES provider. And then the originating site is where the patient is located at the time of the visit. So just to make sure we have that terminology clear. So from the distance site perspective, under normal circumstances, Medicare does not reimburse RHCs or FQHCs for services as the distance site. Medicaid does reimburse distance site for RHCs and FQHCs. However, as we just discussed, Medicaid doesn't reimburse DSMES services separately for these providers. Under the waivers of the public health emergency, the COVID-19 public health emergency, Medicare is allowing RHCs and FQHCs to provide distance site services. So if there's an FQHC who does DSMES, they can do that via telehealth as a distance site. So many RHCs and FQHCs will serve as the originating site or the patient site for telehealth services because they normally can't. In normal non-public health emergency circumstances, they normally can't serve as a distance site. Medicare does reimburse RHCs and FQHCs that are located in rural areas for serving as the originating site. And again, under normal circumstances, the provider must be in a rural area to serve as the originating site. The public health emergency has waived this geographic restriction. Medicaid does not reimburse an originating site fee at any time now or post-pandemic. They do not reimburse an originating site fee. So before I go into a little bit more detail about the billing piece, let's talk about the different considerations for providing DSMES via telehealth versus in person. So first, I want to emphasize what doesn't change when the services are provided via telehealth. The structure and requirements, the curriculum, the delivery, the patients that qualify, and the referral process, all of that stays the same. So generally the program itself doesn't change. And so all of the benefits for the patient and the cost savings and all of those things still do apply. So what's different? At the distance site, there are some specific telehealth codes, which we'll talk about in a moment. And additionally, Medicare does limit the types of providers who can deliver and get reimbursed for telehealth services. So again, we mentioned during normal circumstances, RHCs and FQHCs are not allowed. During the public health emergency, they can be a distance site. But under normal circumstances, the list that can provide telehealth are physicians, NPs, PAs, nurse midwife, CNS, CRNA, clinical psychologists and clinical social workers, and registered dietitians and nutrition professionals. This is particularly important when considering DSMES because not all providers who are qualified to deliver DSMES are included on this list to receive reimbursement from Medicare if they're doing it via telehealth. So providers who are doing DSMES via telehealth need to be careful to ensure that the appropriate professionals are delivering the services. Now, during the public health emergency, Medicare has put out guidance that they are allowing providers, all providers who may bill independently for services, they can provide services via telehealth and get reimbursed. So ADCES, which is one of the accrediting bodies of DSMES, has published guidance that they are interpreting this to mean that any accredited and recognized DSMET program can offer and bill for DSMT services regardless of the provider furnishing the services, because the DSMES programs bill under the program NPI and not the individual provider NPI. But again, this is only during the public health emergency. And if this list of providers is going to be expanded permanently, we don't know yet. There hasn't been any additional guidance on that. So right now it's just during the public health emergency. If the patient is at home, the distant site provider, of course, needs to ensure that the patient is able to connect, which can be an issue in rural communities. We've seen that. However, there are a lot of potential unique benefits when the patient's at home and they're getting services via telehealth. The no-show rates are decreased. That's a very common thing that we hear. Patients are showing up for their visits because they don't have to find transportation. There's more of an opportunity to get engagement from the family or the other household members that are there who the patient may need support from in implementing the changes they're learning in DSMES. And then the provider also has the opportunity to observe the home environment and get better insight on how to support the patient. So that a lot of times can be really beneficial, especially in a lifestyle change type of program. It is important here to note that Medicare typically doesn't reimburse telehealth services provided at home. They have removed the originating site limitations during the public health emergency. So we're hoping some of that stays in place longer term after the public health emergency, but it's lifted right now during the PHE. For patients who were located at an originating site, the distance site provider will need to make sure that they develop a scheduling process with that clinic so that the space where the patients need to be is available when it's needed, and that the facility has adequate staff and the right equipment so that the patient can get connected at the time of the visit. Having the patient at an originating site does reduce the risk of having technology issues if the patient doesn't have good connectivity at home. It also helps to increase the engagement and the collaboration between the primary care provider and the DSMES provider, because you're working together to coordinate those visits. So it helps create a little bit better collaboration between the two providers who are both supporting that patient. At the originating site where the patient is, you would normally refer the patient out to a DSMES service, and they go, hopefully, and then they go in person, and then the DSMES provider may send you some feedback with how the classes are going and what they're seeing with that patient. However, in this case, if you have the patient come into your clinic for the visit, it gives you an additional touch point with that patient to better monitor their status and what's going on with them. And then you have them there if they need a medically necessary visit. So if it's about the time to get their A1C checked, or they need a wellness visit, or whatever the case might be, if they're already there, you can schedule them on the same day for their medically necessary visit. So it's more convenient for everybody. And then since you're working collaboratively with that DSMES provider on scheduling and facilitating, you have better communication with them. And so you have better insight into how the classes are going and what's happening with that patient. And then again, for Medicare, you can bill that originating site fee. And just a reminder that only if you don't have a medically necessary visit, if you have a medical visit, you would bill for that visit. So I'm going to go a little bit more detail about the billing and reimbursement. So as the distance site, remember that FQHCs can currently bill Medicare as the distance site for telehealth during the public health emergency. However, rather than billing the normal DSMES codes that you would bill if they were in person, the FQHC is going to bill that G2025 code, which is the telehealth code. And the telehealth rate that's been established at this time is the 9203. So the payment would be the lower of that or the actual charges. And the services are subject to co-insurance. So Medicare would pay the 80% and the patient the 20%. And again, RHCs are not paid separately for DSMES by either Medicare or Medicaid. If you're the originating site where the patient is located, again, Medicaid doesn't pay an originating site fee, but Medicare for RHCs and FQHCs that are in rural areas, they can bill that originating site code, which is Q3014, and they'll receive, again, the lower of either the originating site rate, which now is about $26.65, or the actual charges. And again, is the co-insurance, and it's that 80-20 split. And if you do have a medically necessary visit on the same day, you would bill the visit, and then you would bill the telehealth on a separate, the originating site code on a separate line with the revenue code of 078X, but you would only get paid for that encounter rate. You wouldn't get the 26 in addition to that. Again, I want to emphasize that the geographic restrictions are lifted right now during the public health emergency, but during normal time, the provider has to be in a rural area. So I know that's a lot of information to take in, but if you were able to process some of it and you are interested in connecting your patient to a DSMES via telehealth, I do want to tell you a little bit about the project that we are working on at Well Ahead. So we all know that the rates of type 2 diabetes in our state are very high. And Well Ahead recognizes that for many of the reasons we just discussed, patients in rural areas a lot of times aren't receiving the DSMES services that could really benefit them. So we are working to expand access to DSMES services to patients in rural areas through telehealth. We are currently partnered with Lolly Kemp Regional Medical Center, who is a DSMES provider, and they are partnering with rural RHCs and FQHCs to provide DSMES education to their patients via telehealth. They are currently seeking at least 2 clinics to partner with in 2021, and they may have capacity to partner with some additional clinics later in this year. And then we're also working to identify a second DSMES provider partner who will hopefully be seeking to partner with 3 clinics later this year. Since we haven't finalized our agreement with that second provider yet, I can't give any names or any more details, but because we're still early in the process, they likely won't be ready to start providing services until late summer or early fall at the earliest. So for clinics who participate in this project, they will need to establish a relationship with the DSMES provider and work with them to implement this program. So this includes implementing the referral process, the scheduling process, and ensuring that they have the appropriate equipment and the staff, training and time to support the sessions. The clinics will also have a separate agreement with Well Ahead, because we oversee the project and we're supporting the implementation. We are rigorously evaluating this project, which basically means that it involves patient surveys, de-identified patient data, and some interviews. So clinics who participate would be required to support these efforts by administering patient surveys, providing us basic data, and participating in some interviews. The data that we're asking for is A1Cs, weight, and blood pressure. So pretty basic de-identified information. And then the project leads at the clinic would participate in an interview once or twice a year with our evaluator, and they would just talk about what's going well with the project, what are the barriers you're facing, and how are we overcoming those. So that's in addition to patient surveys that the clinic would administer and then send back to us, again, de-identified. That's the data that we would need for the evaluation piece. As mentioned, Wellhead is providing overall project implementation support and guidance, and we're also providing clinics with technical assistance as needed regarding implementation, regulatory requirements, and billing requirements. And as part of our agreement with the clinics, we can provide some financial support to help offset the cost of the staff time for the implementation work and the training, as well as some funding to support the purchase of some of the basic telemedicine equipment that the clinic will need to connect those patients to the DSMES visit. And of course, we'll establish that connection between the clinic and the DSMES provider and serve as the facilitator of that relationship until the project is well established and communication is flowing well between the provider and the clinic. Our ultimate goal with this project is to help overcome some of those initial kind of barriers to entry into a DSMES telehealth connection, so we can create a sustainable program that can function well and can benefit the clinic, the DSMES provider, and the patients without needing continued direct support from Wellhead. So we're trying to get this relationship up and established and running, and then we can be hands-off and it works well for everyone involved and is a self-sustaining program. So if you are interested in serving as an originating site clinic for this program, you can complete our application, which is actually linked here in the slide. And then it should also be included in the recap email that'll be sent out after to all the registered participants. All RHCs and FQHCs are welcome to apply. We have identified several underserved parishes, which we list here, and the clinics in those parishes will be given priority for selection to participate in the project. However, depending on the amount of interest we have and the capacity that we have to support, we may be able to partner with clinics outside of these parishes. So if you're not in one of these parishes and you're interested, please go ahead and apply, and hopefully we will be able to include you at some point in the project. If you have questions, want more information before or after filling out an application, you can reach out to me directly, and my email address is listed there, danae.aber@la.gov.
Thank you, Danae, for that insightful presentation. We will now open up the floor for questions. Please type any of your questions you may have in our Q&A box, which is located at the bottom of the screen.
All right, I see one here that says, is there a required documentation in providing DSMES? So I know that there are all of those standards that are listed, all of that is required to be documented. And I believe that there may be some regular reporting that has to be done to whoever, if ADA or ADCES, depending on which program you're recognized or accredited through. I think they have some documentation that you have to submit through there, but that's the documentation that I'm aware of for that piece of it. And I would recommend, it probably varies based on if it's ADA or ADCES. So I would recommend looking more into their requirements. If you're looking for one in particular, if you want to send us that via email, we could probably provide you some links. I'm sure there's some on our website to the more specific requirements about documentation. Okay, I'm reading a comment here. I think this is an excellent project, and hopefully we can also measure compliance to their medication, correlating it with the hemoglobin A1C. There's a disproportionate effect of diabetes among African American and Native Americans. Are we addressing this disparity? Are there RHCs or FQHCs directing helping these population groups. So we do have, I think, to kind of answer your question broadly, I think there are FQHCs, because again, FQHCs can get reimbursed by Medicare for DSMES. So I think there are FQHCs who have programs that are specific for those patient populations. And there are DSMES curriculums that are specifically culturally adapted for those populations. And we could probably help you locate those. We do have a separate project that's not particularly via telehealth, but it is a DSMES project where we are supporting the implementation of a DSMES curriculum called Wisdom Power Control, which is culturally adapted for the African American community. So if you're interested in more information about that, please reach out to us and we'll be happy to provide you more information about that program. Will this presentation be sent out as a follow-up? Yes, I think the recording and the slides will be on our website, and I believe they're going to go out via email to all the registered participants as well.
Yes, I'd like to just reiterate that once all presentation materials, including the presentation, PDF, and also the recording, once those are available, we will be sending out a recap email later this week to all registered participants.
Great, thanks. I'm going to give a few more minutes for questions. I'm actually going to just move to the next slide real quick. These are links, which again, when you get the slides, you will actually have to click on these links. These are several of the references that I used in putting the information for this presentation together, and references that may be valuable to you if you're trying to implement a program. So these are all really good resources. And then also if you want to go to walpen.org, there's a ton of resources there as well. Let's see. Are we doing remote monitoring devices in this program? In the project that we are doing, DSMES via telehealth, we are not doing anything with remote monitoring devices at this time. It's the program is structured for the patient coming into the clinic as an originating site and connecting that way. So that's how our project is set up. Thank you for the kind comments about the presentation. Give it just another minute to see if anyone's still typing some questions. Just getting some additional comments. So I think we might be done with questions.
All right. Thank you again, Danae, for that great presentation. And thank you all for joining us today. Please visit www.walpen, that's walpen.org, to find out more information about our programs and resources. Also, look out for our bi-monthly newsletters with updates on trainings, resources, and other opportunities that we offer. Thanks for joining us today and for helping us move Louisiana's health forward.
Thanks, everyone.